Thank you for being part of this lecture today. I must say that I feel like a radio presenter talking to a virtual audience. But for the next 30 to 40 minutes, I will be talking about anesthesia for cleft surgeries using these guidelines. I will talk about the peculiarities of children, perioperative preparation to include the challenges we see, how to optimize the patients, investigations, fasting guidelines, and pre-medication. I will talk about preparation for anesthesia, the intraoperative management to include induction, airway management, maintenance, fluid and blood transfusion, and pain management. I will conclude with talking about post-operative management, talking about pain control and its complications. Most cleft surgeries are performed in children of various ages. The age definitions from other parts of the world may not hold fast here because of delayed presentation. Most cleft lip repairs are done from 3 months of age and cleft palates before the speech develops. However, a few centers do perform neonatal lip repair, especially in the developed world. The scope of surgeries include lip repair, palate repair, pharyngoplasty, and bone graft, especially in older children and in adults. Children are not small adults. They differ anatomically, physiologically, pharmacologically, and psychologically from adults. And all these factors, in addition to skills required to manage difficult intubation, are needed for safe conduct of anesthesia for cleft surgeries. Anesthetists must therefore be competent to deal with the child patient, difficult airway, coexisting congenital abnormalities, as well as the problems of a shared field. I work at the Lagos University Teaching Hospital, and since 2007, we have performed over 750 cases successfully. Our cleft team consists of consultant pediatric anesthetists, trainees, and technicians, but the setup differs across the region. Whatever setup you may find yourself in, patient selection and safety is paramount. Cleft surgeries are usually performed as inpatient surgery, but day case surgeries have also been done successfully. Remember that most outreach and mission surgeries are day cases and should be done with the same degree of appropriate patient selection and safety. There must also be facilities for unanticipated hospital admission if complications occur. What are preoperative challenges? In addition to regular challenges of the pediatric patient, there are also the peculiar problems associated with the cleft deformity. Literature states that 20% of children will have underlying syndromes or systemic abnormalities, mostly of the heart and the airway. Unpublished data in Luth shows that the risk of cardiac involvement is 9 times higher in non-syndromic cleft patients compared to their controls. Therefore, it is important that we allow time to assess and optimize these patients. Recurrent chest infections is the most common preoperative challenge, and I will talk in detail about this a little later. Congenital heart diseases are common, and they are usually atrial septal defects, ventricular septal defects, and sometimes tetralogy of Fallot. These children will require cardiology consults to identify the pathology and optimize the patient. It should be ensured that the child is not in failure before surgery, and appropriate anesthesia is provided according to the pathophysiology of the heart condition. There are over 200 syndromes associated with cleft lip and palate. The presence of craniofacial abnormalities should alert the anesthetist to the possibility of a difficult airway. Feeding is difficult in cleft children, as they may not be able to form a seal around the nipple. This leads to various degrees of poor nutrition. The children may be anemic or dehydrated with electrolyte abnormalities. All these must be corrected before surgery. Chronic airway obstruction occurs because of smaller maxillary and mandibular dimensions, as well as altered upper airway muscle activity. Children will have a history of snoring, apnea during feeds, and prolonged feeding time. Some older children may develop right ventricular failure and cor pulmonale due to chronic hypoxia. These children also need to be optimized by the cardiologist. Children are prone to obstructive sleep apnea. Children with obstructive sleep apnea are prone to upper airway obstruction at induction and are particularly sensitive to sedatives. Other renal and abdominal defects may coexist with cleft deformities. Recurrent respiratory tract infection is common in children with cleft palate. Milk refluxes into the nasal passages during feeding, resulting in chronic rhinorrhea. Besides upper respiratory tract infection, sinusitis and otitis are common. Important features include cough, colored rhinorrhea, malaise, fever, chest signs, and a raised white cell count. Respiratory tract infection increases the risk of perioperative respiratory complications like turbulent induction due to blockage of the nostrils, and the risk of laryngeal spasm because of a hyperactive airway. Airway edema and postoperative lower respiratory tract infection may also occur. Therefore, any child with respiratory tract infection should have surgery postponed. If it's upper respiratory tract infection, 1 week after antibiotics and resolution of symptoms. And if the child has a lower respiratory tract infection, 2 weeks after antibiotics and resolution of symptoms. Airway assessment is not easy in children, and as they may not cooperate with routine airway assessments. Besides that, the recommended cutoffs we know and used are based on adult patients. Difficult airway may, however, be anticipated whenever there is retronaphia or micronaphia, if there are large or bilateral clefts, and in syndromic children. All these are aggravated if the child is less than 6 months old. It may therefore be necessary to wait for the child to grow, as airway problems improve with increasing age, except in syndromic children. Whenever difficult airway is anticipated, adequate preparation is necessary for the safe conduct of anesthesia. Here, we have a picture on the left of one of our patients with bilateral clefts and the protruding maxilla. This results in difficulty in inserting a laryngoscope. And on the right is a child with pierobin, and the red arrow here shows the marked micronaphia that the child presented with. This particular child was impossible to intubate despite being scheduled for surgery 3 times. And this could be because we did not have more sophisticated airway equipment in my institution. These are pictures of some children with obvious, some syndromic children with obvious fasces that would direct you to anticipate a difficult intubation or a difficult airway. I must say that all children were intubated successfully in our hospital. Routine investigations are indicated for cleft surgeries, which should include a full blood count, electrolytes, and urea. Platelet count and clotting profile are especially important in palate repair. A chest X-ray, ECG, and echocardiogram are performed as indicated. Cleft surgeries are not emergencies, and the children should be in the best clinical state before surgery. Optimization may therefore include rehydration and correction of any electrolyte abnormalities, nutritional support, hematinics, treatment of any respiratory tract infection, and heart failure. Routine fasting guidelines are instituted, and 2 hours to clear fluids should really be encouraged. It prevents thirst and dehydration and the restlessness that follows, and makes it easier to induce the children. Intravenous fluids may be necessary in small infants, patients with sickle cell disease, and when surgery is unnecessarily delayed. Pre-medication may be given as indicated, though sedatives are best avoided. Anticholinergics are given if ketamine is to be used, but preferably this is done pre-induction to prevent the dry, uncomfortable mouth that the antisialogogues produce. Blood is cross-matched for palatal or lip revision only. For cleft lip surgery, for primary cleft lip surgery, the frequency of blood transfusion is low, as was shown in these two studies in my institution. Therefore, in order to prevent wastage of this scarce resource, it is advisable to group and save only. And this is what we have been practicing in my institution with great success. It is best to schedule the smallest patients first to minimize hypoglycemia and dehydration from prolonged fasting. Also, major cases with the potential for prolonged surgery are scheduled early in the day, so that we can have enough time to observe and monitor them for any post-operative complications. Preparation for anesthesia involves appropriately skilled personnel, equipment, monitoring, resuscitation drugs, as well as difficult airway equipment. In the array of the shown below, we can see the pediatric McCoy here on the left, and we can see laryngeal mask airways and eye gels necessary for difficult intubation. Unfortunately, we do not have a video laryngoscope in my hospital. Some of you are fortunate to have that. Techniques of anesthesia vary, but should be appropriate for the child and the procedure. Share your plan with your team and have alternate plans in case plan A fails. Separation anxiety is a problem with children over the age of one year. Thus, the use of distraction techniques, cartoons, or parental presence are encouraged. Please note that telling a child, "I will call policeman," or "Do you want me to give you injection?" is not considered adequate distraction techniques. Oral midazolam may be given, but the child should be monitored thereafter because of its sedative effects. Sometimes I have had to resort to intramuscular ketamine given to the child while the child is still in his parents' arms, when the child is particularly uncooperative. Routine monitoring should be established before induction. All efforts must be made not to frighten the child while doing this. IV access is obtained either pre-operatively, pre-induction after EMLA application, or after inhalational induction. Accurate documentation throughout the procedure is vital. Pre-oxygenation is vital in those children with anticipated difficult airway or cardiac disease. Induction can be inhalational using incremental halothane or sevoflurane. Don't forget that halothane causes bradycardia. Sevoflurane is cardiostable and good for children with cardiac diseases. Induction can also be started with a high concentration, up to 8%, therefore shortening induction time. Intravenous induction can be achieved with thiopentone or propofol. Sometimes ketamine is used. IV induction, however, should not be used in children with difficult airway or chronic airway obstruction, as the potential to lose the airway is very high. As much as possible, do not let the child cry, as crying produces secretions and nasal discharge that can cause turbulent induction with the risk of laryngeal spasm. Play with the child, blow the balloon, sing a song, but make sure that the song is appropriate. I was once singing "Barney is a Dinosaur" to a child, and my registrar promptly told me that I was old school, that it is no more Barney, and that it should be Baby Shark. So the next time I tried Baby Shark, and the child wanted Wizkid. So you need to find the appropriate distraction for the child. I frequently induce children sitting up or being carried. There's no law that says that the child has to be lying supine to be induced. Children with obstructive sleep apnea will have early airway obstruction due to poor muscle tone, and a jaw thrust or change to lateral position may improve this. Otherwise, you may need to insert an airway or a laryngeal mask airway to deepen the child and then take that out when it is time to intubate. Dexamethasone is given at induction for its many benefits: anti-inflammatory, antiemetic, and it potentiates analgesia. We give it routinely in my institution, but I know that others may reserve it for difficult intubation scenarios or where there's an increased risk of post-operative airway swelling. Intubation is the gold standard for cleft surgeries. This can be done under deep inhalational anesthesia or after succinylmethonium. Don't forget that the combination of succinylmethonium after halothane induction and laryngoscopy can result in bradycardia or even cardiac arrest, especially in infants. You may therefore need to pre-treat with atropine or glycopyrrolate. Non-depolarizing muscle relaxants are a good option if test ventilation is positive. And the type of tracheal tube that we're going to insert depends on the procedure. It is important that an experienced laryngoscopist is available for intubation. Intubation is mostly always by the oral route, though the nasal route has also been used successfully. Repeated intubation attempts can lead to hypoxia, bradycardia, and cardiac arrest, parasympathetic stimulation, bradycardia, and cardiac arrest, airway trauma, which will make intubation even more difficult, as well as airway edema. It is, however, safer to wake the child if intubation proves to be difficult than continue trying and trying and trying because of these complications that I have listed earlier. Insertion of the laryngoscope blade may be tricky in patients with cleft of the alveolus and bilateral clefts. This picture shows the use of a gauze roll inserted here, which helps prevent the blade from slipping into the defect. One might also consider using a straight blade laryngoscope or the lateral position. A Portex or PVC tubes are shown here. Those are regular tubes. They are suitable for lip repair, but they may get kinked by the mouth gag during palatal surgery. A south polar tube, on the other hand, takes the breathing circuit away from the site of surgery, and it is not easily kinked by the mouth gag. There is, however, a risk of endobronchial intubation because of the fixed length from the knee here to the tip, which may be too long in some children. The armored tubes have a wire spiral, as you can see here, within the walls, which prevents it from kinking. It doesn't kink. They are therefore best for palatal surgery. However, a size smaller than calculated is used because of its thicker walls. The flexible LMA has also been used successfully for cleft lip repairs. It can also be used as a conduit for fiber optic bronchoscopy when there's failed intubation. A video laryngoscope is also indicated when intubation is difficult. A throat pack is inserted around the tube to prevent air leaks and contamination of the airway with blood and debris, and it should be well labeled. I prefer to put the label here on the forehead so that when the draping comes off at the end of surgery, it is clearly visible and acts as a reminder. The red arrow here is pointing to the throat pack around the endotracheal tube. The appropriate position for surgery is neck extended and head flexed, as shown in this picture. using a head ring and a shoulder roll. This may, however, cause the tube to migrate outwards. It is therefore necessary that multiple tube checks are done to ensure continued the correct tube placement. The tube should be checked after intubation, after securing the tracheal tube, after insertion of the throat pack, after positioning, and after insertion of a mouth gag. Standard monitoring is essential as shown. We have the precordial stethoscope, capnography, pulse oximetry, ECG, blood pressure, and temperature. This must also include the presence of a competent and vigilant anesthetist. The airway pressure monitor on the ventilator is also useful to monitor for any tube problems. Here we have a vigilant anesthetist, the 5G model, with numerous eyes, numerous ears, numerous hands, and wheels on the feet. But I want you to watch the surgeon, to note the watch the surgeon eye and the watch the surgeon sensor, which I will talk about later. For the trainees among us today, don't worry. The faculty chair will bestow these essential natural monitoring devices on you at convocation. But he's only going to bestow the 5G model. You will have to, he's only going to bestow the 3G model. You will have to attain the 5G model after acquiring more clinical experience. Maintenance of anesthesia can be achieved with inhalational agents in oxygen and air or nitrous oxide. Don't forget that halothane causes dysrhythmias with adrenaline infiltration. So you have to cross-check the dilution that is intended for infiltration. The dose should not exceed 2 milligrams per kg when halothane is used, and a concentration of 1 in 200,000 is safe and reduces blood loss significantly. Halothane, however, has a longer time to recovery. Sevoflurane and desflurane provide the rapid recovery needed for the control of the airway post-surgery. In this environment, isoflurane is frequently used and it is adequate. Total intravenous anesthesia with propofol and remifentanil have also been used successfully. Ketamine, as I put in brackets, may also be used, but knowing its drawbacks. Should the child breathe spontaneously or have controlled ventilation? Both have their advantages as listed, and the anesthetist should use that technique which is safe for the patient and that which he or she is familiar with. Spontaneous ventilation is not advised in infants and small children because they tire out easily. I personally prefer controlled ventilation because of the faster recovery and return of reflexes. Warmed fluids should be given according to calculated existing deficits and maintenance. Some children may have cardiac septal defects, and you must ensure that the IV line is free of air bubbles. As earlier said, blood transfusion is uncommon in primary lip repair. Adequate intraoperative analgesia is extremely important for good recovery. And this is achieved using a multimodal approach with paracetamol, non-steroidal anti-inflammatory drugs, opioids, and regional block. Non-steroidal anti-inflammatory drugs are only used in children greater than 6 months of age. Long-acting opioids should only be given if post-operative monitoring is good and should be used with caution in those that have a risk of apnea. There's a controversy over the use of codeine in children. The FDA issued a warning against its use in 2017, so it is best avoided. Dexamethasone and ketamine also provide good analgesia and are opioid sparing as well. Useful regional blocks include infraorbital nerve block for lip surgery, maxillary nerve block for palatal surgery, and local infiltration. Infraorbital nerve blocks with 1 to 3 mils of 0.5% bupivacaine can provide analgesia for up to 12 hours. As this procedure constitutes a shared field, there's limited access to the patient, as shown with this child completely draped for surgery. Therefore, the trachea tube must be well secured before surgery. I was once asked to comment about whether mainstream capnography would be useful in cleft surgeries, and my answer was no, because I will not be able to see it. And if I can't see it, I can't use it, because it will be covered by the drapes. We need to ensure that the IV access is within reach and that we can palpate a pulse, check for capillary refill, check for color and temperature by having one of the patient's hands accessible to us during surgery. Besides watching the patient, it is also very prudent to watch the surgeons too. Remember the watch the surgeon eye and sensor on our 5G model. Surgeons can kink, dislodge, or disconnect the tracheal tube. Sometimes I feel that they do this to test to see if we are still watching. They lean on the blood pressure cuff. They obstruct the view of the monitors. They step on the sample line of the capnograph. In fact, the list is endless. This is where your watch the surgeon's sensor and eye comes in place. Adrenaline infiltration and manipulation of the neck may have dire consequences. And so therefore, good communication with surgeons is critical, is vital, and cannot be overemphasized. We conducted a study in my institution to investigate the respiratory and airway complications following cleft surgery. We noted that the highest incidence was in patients with cleft lip and palate, 50%, and the lowest was in those with cleft lip only, 15.8%. We had 2% incidence of failed intubation, difficult intubation, accidental intubation, and tube compression. Tube disconnection occurred in 6%. That must have been during the days in which I was a 3G model, hadn't improved to my 5G model. Bronchospasm occurred in 4%, while laryngeal spasm occurred in 6% of children. There was a significant association between airway complications and cleft palate surgery. At the end of surgery, the oropharynx is gently inspected and the throat pack removed. This must be documented. The throat pack should be part of the routine swab count of the WHO surgical safety checklist. The child is extubated fully awake in the lateral position after antagonizing the residual neuromuscular blockers. 100% oxygen is administered and the child watched as airway obstruction can occur post-extubation. A clear and patent airway must be ensured before the child is transferred to the recovery room. Causes of immediate airway obstruction include laryngeal spasm, blood clots, retained throat pack, and tongue swelling. Some recommend inserting a nasopharyngeal airway before extubation in patients with predicted post-operative airway compromise, like patients with Pierre-Rubin sequence, or any patient that has demonstrated loss of pharyngeal tone and airway obstruction at induction, or in any cases where tongue swelling is obvious. You can insert a nasopharyngeal airway before extubation. Otherwise, you leave the patient intubated till the swelling has subsided and administer steroids. This is for tongue swelling. Some surgeons may insert a tongue stitch, which can be used to pull the tongue forward and help to manage any obvious problems with the airway. All children must have a period of recovery of 1 to 2 hours to monitor them, to provide analgesia and oxygen, and to manage any complications. There must be a dedicated area for this with appropriate staffing and equipment. And this can range from a well-established post-anesthetic care unit. Some places may recover the patient on the corridor. Some may recover the patients in the theater. Wherever you recover the patients, you must have adequate equipment and staffing. The child must only be transferred to the ward when stable with no signs of airway compromise. Post-operative pain management starts preemptively at induction and should be continued regularly to prevent breakthrough pain. Good intraoperative analgesia produces good post-operative analgesia. We should use appropriate pain scores for the age of the child, either the FLAC, the FACES, or the VAS scores. Paracetamol and non-steroidal anti-inflammatory drugs are usually sufficient for post-operative pain relief. Sometimes an opiate is indicated, and this should be given, provided adequate monitoring, oxygen therapy, and naloxone are available. The routes of administration can either be by titrated IV boluses, nurse-controlled analgesia, if we practice that in our institution, or IM injection. IM injection is least favored, but is probably still the most used method in our environment. Children do not like injections, and we should move from IM injections to small doses of IV injections for them. Don't forget non-pharmacological therapy, and the parents should be brought in early so that they can cuddle the child and comfort the child, and this goes a long way. Cleft surgeries are not without complications, of which airway obstruction is the commonest. It is important to stress that if you have a restless and difficult child, he may just be demonstrating signs of hypoxia due to airway obstruction, and this should be sorted out before resorting to giving the child analgesia or strapping the child down and saying he's a troublesome child. Airway obstruction can be caused by laryngeal spasm, which is managed by suctioning, oxygen therapy, and the application of CPAP with or without assisted ventilation, depending on whether it is partial or complete. Sometimes suxamethonium and atropine are needed to break the spasm. Laryngeal spasm, though, is more common with secretions in the airway and in patients with upper respiratory tract infection or asthma, and it occurs most frequently immediately post-extubation. Here we have the pictures of showing a normal laryngeal inlet here, and over here we have partial laryngeal spasm, and down here we have complete laryngeal spasm. Airway edema may occur post-operatively due to the use of a large tracheal tube, repeated instrumentation, or overinflated tracheal cuff. The management includes oxygenation, nebulized adrenaline, and IV dexamethasone. If there's a need for intubation, a smaller size tube is used. There may be bleeding into the airway from disruption of sutures. Positioning, suctioning, fluid resuscitation are indicated while the surgeons are called for any intervention. Retained throat pack should not be a problem with the guidelines I have discussed earlier, if those guidelines are followed. Post-operative nausea and vomiting may be due to anesthetic agents used like ketamine, opioids, nitrous oxides, or may be due to pain and dehydration. If it is allowed to continue, sutures may be disrupted, causing bleeding into the airway. If prolonged, dehydration, hypovolemia, and electrolyte derangement may ensue. The management is to put the patient in a lateral position and provide suctioning as well as fluid resuscitation. Additional antiemetics are given, which could be ondansetron or metoclopramide. Delayed recovery and shivering are managed according to established anesthesia guidelines. In conclusion, Successful anesthesia for cleft surgeries require appropriate patient assessment and optimization and safe conduct of anesthesia. The choice of anesthetic agents should ensure rapid recovery with minimal sedative and respiratory depressant effects. Don't forget that quite a number of these children may have problems with their pharyngeal muscles. And if there's any residual sedative effect, you would have airway obstruction and airway compromise. The anesthetist should be vigilant as access to the patient is limited. And this vigilance uses clinical monitoring as well as equipment monitoring and good communication with the surgeons. These are my references, and I would like to acknowledge the following people: Dr. Ohuoba and Dr. Ashinyobi, who helped with my presentation, and Dr. Olowu and Oshokoya, past senior registrars in my department, who helped with the photographs. Thank you very much for your attention.
Yeah. Well, thanks, Professor Desalu, for this very lucid presentation. I hope I can be heard.
Yes, I can hear you.
Okay. Yeah. It's been quite clear, and I'm sure most members of the audience heard you well, and your usual way of getting things well arranged. There are also a whole set of questions in the chat room, covering the various aspects that you alluded to. And as we get there, it will be possible for you to now respond to some of them.
I'm sorry, how do I get to, do I get to the chat room, or are you going to read out the questions?
Professor Gibrum, while you are still looking at the chat room, I think I'll take a few questions that have come in already. The first, thank you very much for the lecture, very lucid. The first question is from Fick, Dr. Fick, if I'm right. What's the role of tracheostomy in Pierre-Robin syndrome? The role of tracheostomy in Pierre-Robin syndrome. I'll take about 3 or 4 questions, then you can respond to that. And then the next question that was asked is, I think, intraorbital nerve block in cleft surgery. What's your experience? Infraorbital nerve block in cleft surgery. Do you use?
Thank you very much. Can I go ahead and answer them?
Please do.
Okay. The role of tracheostomy in Pierre-Robin syndrome. I had an experience with the patient I showed, Pierre-Robin syndrome, and we were unable to intubate the patient. But we didn't have a video laryngoscope, so I don't know whether a video laryngoscope would have made it better. But Pierre-Robin syndrome is well known for presenting difficult intubation. You would ask me what happened to the child in the end. Did we get to do the case? And I would tell you, yes, we got to do the case, but we stumbled onto the case because on one of these, the last time we tried to intubate the patient, and we couldn't, we put in a laryngeal mask airway and decided to abandon the surgery. However, in taking out the laryngeal mask airway, we couldn't maintain the patient's airway. So the patient had to have a tracheostomy. We had to get the ENT surgeons who were present because it was a difficult intubation and it was not only was it a difficult intubation, it had been tried twice before. So the ENT surgeons put in a tracheostomy, and then we went ahead and did the palate. So if you do not have any other way of intubating the patient and you have tried, a tracheostomy could be the only option. Tracheostomies are not easy in children, and they also have a higher morbidity. So the decision to do a tracheostomy must not be taken lightly. the child should be allowed to grow a bit, and we'll see whether we can have another attempt at intubating the child. Because usually when they grow, we may have more space. But in Pierre Robin, it's small jaw and large tongue. Growth doesn't really help the issue. So yes, there could be a place for tracheostomy, but that should not be taken lightly. You must have a competent ENT surgeon, and you must be well aware that there's increased morbidity with tracheostomy. If that is all you have in your institution and you cannot refer the patient to another institution for a non-surgical control of the airway, then that is your only option. Regarding infraorbital nerve block, we have very good experience of it in our institution. It's usually placed by the surgeons. It's easy to do, and it works very well. So we have good experience with it. But that is for cleft lip surgery only, that the infraorbital nerve block works well for cleft lip surgery only. Have I answered your questions?
Yes, thank you very much. There are a few more. One question here is, how many attempts after how many attempts do we classify it as a failed intubation? That's one question. The next question is, are chest x-rays routine for cleft and palate repairs? And the third question I'll ask for this batch is, what are common examples of small dose analgesia? And let me add one more. And regarding cough and non-cough endotracheal tubes, what is your preference, and do you have a reason for that?
Okay. The first question was talking about failed intubation and the number of attempts. It depends on the experience of the laryngoscopist. Sometimes, if you have a most experienced laryngoscopist doing laryngoscopy, he may do laryngoscopy one time and know that this child is impossible to intubate and call it a failed intubation. But a lot of the literature will tell you after 3 attempts at laryngoscopy, you should abandon the laryngoscopy. And with each attempt, it is important that you just don't go in and make the same attempt. Something has to change. What will not change is the patient's anatomy. So something has to change. You have to change something. There's no point going in and doing the same thing 3 times. That's why it is important to prepare and have all your difficult airway equipment with you and to discuss with your team. What I usually do is I would go with the first attempt, probably with the McCoy, so that I don't have to take out one laryngoscope and then introduce the McCoy. But I would discuss with my team members and I would let them know my view, my Comac and Lahane view, so they know how they can help me. I'll discuss with my team members and say, well, if I go in and I can't see, I want you to apply external laryngeal maneuver. I would then try to a lateral position. If I can't see, I'll come out and then I would insert a stylet or some. You'd go step by step with your team. Don't forget the use of a bougie. A bougie is also very important. But as I said at the start, an experienced laryngoscopist can declare a failed attempt at the first attempt if you look and you know, I can't see. Even with external laryngeal maneuver, even with the lateral position, I can't see. So that's how I would answer that question. Is chest x-ray routine for patients coming in for cleft lip and palate? Chest x-ray is not routine for any patients coming in for anesthesia, except you have an indication for it. With chest x-ray, whatever you're looking out for in the chest x-ray, you must have heard something on auscultation or seen something in the patient's signs and symptoms to prompt you to do a chest x-ray. If you're looking for cardiac problems, then an ECG and a consult with the cardiologist is best. So a chest x-ray is done when indicated. Cuffed or non-cuffed tubes. I use cuffed tubes in my practice. because I'm used to it. I like the fact that the cuff is going to prevent debris and blood from going into the airway. But I am very careful about how much volume I inject into the cuff. I am very careful about how much volume I inject into the cuff because I do not want to have airway edema in the post-operative period. Some authorities use non-cuffed tubes, but the endotracheal tubes we have now are low pressure, high volume cuffs, which should not give you too much problem if you stick to the guidelines of how to inflate the cuff and the amount of air to put in the cuff. It shouldn't give you too much problems in the post-operative period to do with airway edema. Yes.
Thank you very much. There was a question on common examples of small dose anesthesia.
Analgesics, you mean?
Analgesics. But
small,
before,
yes.
I want to combine 2 or 3 more so that we can take them. Small dose analgesia. And then the question was, what is the fear of using non-steroidal anti-inflammatory drugs for children less than 6 months of age? And is there a protocol for preoperative blood investigations for cleft surgery? And the last for this batch, we still have more, but the last for this batch is a long kind of comment on question that the size of endotracheal tubes, we look at the internal diameters, but we're aware that the external diameter may differ depending on manufacturer. How do we cope with that when we're using different products? Thank you for now.
Internal diameter versus external diameter. Small dose analgesia. You can only give small dose analgesia. You can only give small dose of any analgesic if you are combining it with something else. Because all drugs have their therapeutic doses and therapeutic levels. If you do not give enough, then you do not get the effect that you are looking for. I give you an example. If you want to use morphine, for instance, intraoperatively, you get the dose of morphine for the patient and you titrate it. So if I'm using something like I can give something like 10 micrograms per kg boluses to the child. Even in the post-operative recovery period, your analgesics, especially your opiates, should be given as boluses. 10 micrograms per kg, wait and see. 10 micrograms per kg, wait and see. If you are using ketamine, for instance, for analgesia, you know that the anesthetic dose of ketamine is 1 to 2 milligrams per kg. So you are looking at smaller doses like 0.1 milligram per kg, giving in boluses, titrated, and watch for the effect. Whatever you give, you must try not to give a full dose. This is in the post-operative period, a full dose in one go, because you could have respiratory depression. And that in itself, it's a problem, trying to get naloxone, ventilate the patient, giving oxygen. You should have those things on board, but you don't want to go into respiratory depression. So you give small doses until you are sure that the child is comfortable, monitoring the respiration, giving oxygen, and monitoring the oxygen saturation. Non-steroidal anti-inflammatory drugs are not given in children less than 6 months because there's a risk that we know that the patent ductus arteriosus is anatomically, functionally or anatomically obliterated by 6 months. It depends on prostaglandins, the presence of prostaglandins. If you give non-steroidal anti-inflammatory drugs, which are antiprostaglandins, it can cause reopening of the patent of a ductus arteriosus that has been functionally closed, and you can get reversal to fetal circulation. It also, we know, has an effect on the renal circulation. That is why it's not given to children less than 6 months. Regarding preoperative blood investigations, I had said earlier, for any surgery, including clefts, we must do a full blood count, hemoglobin, white cell count. We must do urea, electrolytes, and creatinine. We have said that these children may be dehydrated and they may have electrolyte abnormalities, so that needs to be checked. We also want to check for their renal function because sometimes they may have coexisting renal congenital abnormalities. Platelet counts is usually part of fasting of the full blood count, so that usually comes with us for us. But clotting profile should be added on if you're going to have palatal surgery. That's important. Internal diameter versus external diameter of the endotracheal tubes. We know how to calculate the size of the endotracheal tube, but we also know that in children, the smallest part of the airway is the cricoid and not the glottic opening as in adults. So even if you have calculated your tube and that is the proper size for the patient, if it goes through the glottis and doesn't go through the cricoid, it is too big for that patient. You need to step down and take another size. Have I answered your questions?
Yes, I think you've addressed the questions for now. Professor Jibrum, can you continue the question and answer? Professor Jibrum? Okay, while Professor Jibrum is still getting the questions and answers ready, I'll just take 3 or 4 more questions. Professor Jibrum, are you ready?
Yes, I am.
So, can you take the subsequent questions?
If she can she hear me now?
Yes, I can hear you, Prof.
Yeah, just to add something to the one you already addressed, because it was really meant, it was a comment, the question of tube size. It was a comment that we should be more wary because of those differences. So it needed to be taken in that light.
Thank you.
By another anesthetist, as it were. Then there is a question on how you optimize children pre-op who have pre-op anemia. Is there a protocol for that? Another question is on do you need to withhold the retractor during surgery after a period to avoid tongue edema? And
I'm sorry, I don't understand that question. Do we need to
withhold? That is a retractor. Do you need to withhold a mouth retractor when you've had a difficult surgery to reduce tongue edema? That's how it's put, really. So, and then there is I think you've addressed most of them. Then the last one in this series is, how do we reduce the risk of airway complications in patients with enlarged adenoids post-palatoplasty? How do we reduce the risk of airway complications in patients with enlarged adenoids post-palatoplasty? Did you get that?
Yes, I'm just trying to write it down.
How do you reduce the risk of airway complications in patients with enlarged adenoids post-palatoplasty?
Okay.
Then the last one, I don't know if I said that. What's the experience of you and your institution in day case, cleft lip, and palate repair from the anesthetic point of view?
Day case, lip, and palate.
Yes.
Okay, thank you very much.
All right.
The protocol for pre-operative anemia in my institution is to give the child hematinics and improve nutrition. We don't transfuse the patients pre-operatively. We don't transfuse the cleft lip and palate patients pre-operatively for anemia. Most of the time, the anemia that we come across is a mild variation. Because we have complete cleft care in my hospital, they would have been seen in the Cleft clinics. Nutrition would have been improved. They would have been seen by the dietitian. They have a whole food pack that they give them to improve on their nutrition. And it's only when this has been improved and the patient is good to go for surgery that they are scheduled. We have a very good pre-operative cleft team that does that. And so we don't have any indications to transfuse the patient or anything before cleft surgery. The mouth retractor tongue edema, I didn't quite understand what the participant was trying to say there.
You can go on with the others. That's how you put it.
How do we decrease the risk of airway complications with enlarged adenoids post-palatoplasty?
Yes, that's post-palatal surgery.
Post-palatal, so well, pre-palatal surgery, we would know that we were going to have airway problems in the patient because the patient will have signs of obstructive sleep apnea. From the anesthetic point of view, I think the most important thing to do is to watch the child carefully post-operatively. As to timing of extubation, in some centers I know around the world, they can put the child on the nasal CPAP, but we don't have that in my institution. You can put the child on nasal CPAP, and this would help to ensure that the airway remains patent. Regarding day case lip and surgery repair experience in my hospital, I have worked earlier on in my career before the cleft lip and palates were done under the umbrella of Smile Train. I've worked with plastic surgeons who have done cleft lip repair as day cases successfully. So that happens, and that has happened, and I think they have even published a paper about it. They have done successful day case cleft lip repair. With cleft palates, day case may be a bit tricky because it's a longer surgery and they insert the mouth gag, so you have a higher risk of post-operative airway complications, and that will make it a bit tricky to send the patients back. In fact, it would be better to keep the patients in for a couple of hours and maybe send them back home the next day if you want to do short stay. But day case lip repair has been done successfully in my institution by our plastic surgeons.
Okay, I think that's very, very pertinent. That a note of caution that it's inadvisable to do palate and think of sending the patient home. I think that seems to be the message. Is there any experience in your spectrum of palate? You didn't cover pharyngeal surgery for patients with velopharyngeal incompetence. Do you have that? And second is the other bit about when do you advise oral analgesics in the patient's post-op? You've only talked about IV.
Yes. In my institution, we have not started doing velopharyngeal surgery for velopharyngeal incompetence.
Incompetence.
Yes.
Okay.
Incompetence.
Okay.
So when we do start it and we get the experience, I will come back again to tell you, to add it to the lecture.
Okay.
Then oral analgesics. Yes. Oral analgesics can be given as soon as the child can swallow, and it is encouraged in some institutions. I know they give oral analgesics, especially as syrups, even before the child has left the recovery room. For as long as the child can swallow, it is better to change to oral mode of administration. Most people are not happy giving IV analgesics, especially the opiates on the wards. It takes time. You need to be patient. You need to monitor.
Okay. It's been wonderful listening to you. I'm sure the audience has enjoyed you again. On behalf of Smile Train and WACS, I wish to say thank you and a big congratulations. We look forward to maybe meeting you again in the future. Congratulations and thank you very much. For the audience, you've been wonderful and your questions so reflect that you've been very attentive all through the lecture. I hope this is replayed in future. Thank you for being part of this.